This is going to focus on myopic retina problems, when things can be watched, when things need to be worked up, and when to worry. So there's quite a few challenges of myopic retinas. They can be really hard to examine because of the blonde fundus, as well as optical aberrations. You're looking through potentially, a steep cornea, etc. For myopic retinas, it can be hard to know, like, if there's something going on, because even in the best of circumstances, they may not be 20/20. Prescribing glasses and contacts can be really challenging for young high myopes. As I personally experienced as a kid, sometimes I would come home from the eye doctor's office picking up my new glasses, and then spend the next 2 days vomiting. And then my mom would bring me back to the eye doctor because they had what is it called?
Overminus.
Yeah, thank you. I was like, I can't remember what it's called. But
you poor thing.
So anyway, right, an outline of what we're going to talk about. We're going to talk about anatomical changes in the myopic eye, like what causes these retina problems to develop in myopes. We'll talk about the retinal problems that result from myopia, including when to watch, when to do imaging, and when to refer to retina specialists. We'll talk about some problems that might be fixable and therefore need to be treated, as well as problems that aren't fixable. And there's a lot of confusing terms around myopic retina problems, which is kind of why I gave that awkward title to this talk, but we'll kind of straighten them out. All right, so I like to pull random pictures from the internet to do my case study. So this is not the actual person.
I was gonna say he's not that myopic.
Yeah, no, none of these models when you Google have thick glasses. Anyways, he's a 25-year-old computer engineer. He enjoys rock climbing and running. He says, I really want to get LASIK, but my prescription keeps getting stronger every year. They said my eyes shouldn't be changing anymore. So what's going on? Why does he keep getting more nearsighted? Should he get LASIK? What is his risk of developing a vision-threatening eye disease? Thoughts from you guys?
Rachel's on cornea now too, but so I'll punt the LASIK question to her since I've been on cornea. But I think he would keep getting more nearsighted because his myopia is progressing.
Why is it progressing?
I don't know. Like, why does it progress in some people but not in other people? I'm not sure if I haven't.
What's happening with the eye when it progresses?
It gets longer.
Yeah, it's getting. We don't know why they keep getting longer, but we do know that they keep getting longer.
And then his risk of developing a vision-threatening eye disease, I'm not sure, but I wonder if it's proportional to how long his eye is. So the longer his eye, the higher risk that he would be at developing a vision-threatening eye disease.
Yeah, that is correct. And then Rachel?
Yeah, I guess if it truly is like an accurate prescription, he's not like getting overminus progressively, then no, I don't think he should currently get LASIK.
Yeah. All right.
And we know from cornea too that like we try not to perform LASIK on patients when their prescription's changing, and especially if someone's highly myopic, then you have a risk of them needing a touch-up later, which really just means that either their myopia progressed or you didn't get the right prescription.
Yeah. All right, so his risk of developing a vision-threatening eye disease, this is exactly what Teresa talked about. This is a specific thing, chorioretinal atrophy, that occurs with myopia. And you can see that as the axial length gets longer, the percentage of people with this finding increases. It's really very high once you get over 30. The other thing to take away from this graph is that it increases with age. People are not born with these retina problems. So you can see, for example, in this moderate axial length, that in all the eyes it's relatively lower, but once they get over age 40, the incidence is much higher. The very, very approximate lifetime risk of some sort of vision loss in a high myope is 1 in 10. And definitely the risk increases with the degree of myopia. So, all right. So why is he getting more nearsighted? So as Teresa said, there is progressive elongation. If you just thought about it, you might think, oh, the eye might just get bigger all around like a sphere, but it doesn't. It just kind of gets more and more football shaped. There's must be expansion at the equator because of what we observe. In eyes with pathologic myopia with an average age of about 50, the axial length increased in average by 1 millimeter every 10 years. That's pretty significant when we think about, how we think about if there's someone who's a 24 axial length, that's pretty normal, but then, 6 decades later, they could be 30, which is really high. So what happens when that eye gets longer and longer? What are the consequences of this progressive elongation? So there's thinning of all those layers that are getting stretched out, the sclera, the choroid, and the retina. Certain areas might get pooched out more than others. Those are staphylomas. Brooks membrane doesn't really get thinner, but it actually ruptures sometimes. And the vitreous is just more liquefied, I think because it's more dilute. And it's thought that this causes myopes to get posterior vitreous detachments prematurely at a much younger age. So here's another case. He's a 67-year-old pseudophakic male. He was formerly a high myope. He says there's a spot just left and below center in my right eye where I can't see anything. What do you think we should do?
DFE, full eye exam, vision, pupils, pressures, and dilate and look at the back, and then maybe get an OCT.
Okay, very good. So his visual acuity was 20/30. This is what you see on exam.
He has a Fuchs spot.
Yeah, he has a Fuchs spot. So what does a Fuchs spot look like?
So it's that little gray patch right there, and he has a CNVM. And I bet he's got some subretinal fluid, which corresponds to his Amsler grid.
Yeah, so this Fuchs spot is hyperpigmented. Are you able to appreciate these things next to it? What are those?
Those are blood vessels.
There's actually some hemorrhages.
Or hemorrhage?
Yeah, some dots here and like this streak that, I don't know, can you see my mouse?
Yeah.
Okay, yeah, that streak that pooches out. Maybe I should have made it bigger. Maybe it'll become bigger in one more click. I don't know. And then this primarily likely corresponds to a problem on his Amsler grid. Oh, an arrow. Okay, that's not that helpful. Okay, so we talked about ordering an OCT. What do we think could cause this? So Teresa talked about choroidal neovascularization. Choroidal neovascularization, the most common one that we see every day in the retina clinic is wet AMD. But myopia can cause choroidal neovascularization as well. And in this high myope, we definitely suspect that could be the problem. So this is, at the bottom is his baseline OCT. And above, we see his current OCT when he's complaining of that spot. You see that there's a pocket of intraretinal fluid. And, oh, right, I'm supposed to ask the residents what this is. Okay, what else do you think is going on this OCT, Rachel?
So kind of just temporal to the little intraretinal fluid, there's some subretinal, like hyperreflective stuff.
Yes. Yeah, the retina specialist term for subretinal hyperreflective stuff is subretinal hyperreflective material. It just sounds so much more
sophisticated,
professional, but it just means the same. We don't really know what it is. But what can subretinal hyperreflective material be a sign of?
CNVM potentially.
Yeah, exactly. All right, so this is consistent with choroidal neovascularization. Oh, I called it fuzzy stuff. Oh, I used the word.
Hey, I have one more question too.
Yeah.
I saw a patient in clinic with Dr. Vitale today, and he had something called the dome-shaped macula.
Yeah.
And so does this guy have a dome-shaped macula? Because it looks like a little domey in the middle.
Is a little domey. So yeah, maybe a bit, although I thought dome-shaped macula is characterized primarily by subretinal fluid, not by choroidal.
Yeah, this patient did have subretinal fluid, and he was talking about treating him, and this patient had PDT and then kept recurring with his subretinal fluid with anti-VEGF. And so, but it was something that I was going to read about. And he said that he also had high myopia. So it was interesting.
Yeah, dome-shaped macula is cool. Okay, so myopic choroidal neovascularization. So why do myopes get choroidal neovascularization? Some theories on why they get choroidal neovascularization is that they have a thin choroid, that they get retinal hypoxia because that choroid and that choriocapillaris is so thin, and that VEGF is produced. If myopes have other retina problems, the prevalence of choroidal neovascularization is pretty high, 5 to 10%. So I know that, Teresa, you mentioned fluid, but actually it's reasonably common that myopic choroidal neovascularization occurs without fluid. The most common type of neovascularization in wet AMD is type 1, which is those blood vessels are forming under the RPE. Whereas in myopic choroidal neovascularization, the most common type is type 2, which is under the retina and over the RPE. So do you guys know what appearance on fluorescein these correspond to? These two types, roughly?
So type 2 is one where you get early staining of a nice like CFAN whatever, and then like late leakage. And then I think type 1 is more of like a very slow filling. I forget exactly what it looks like, but it's like harder to see sometimes.
Yeah. So this type, they used to call this, or they still call it, classic choroidal neovascularization. You can just see it on the FA better, I think, because it's over the RPE. So it will show up, and you might see a lacy network right away, and it will leak later. And then versus the type 1, they could have like, I think, late leakage of, what is it called? Late leakage of unknown source or something. Or a fibrovascular PED. So some other differences between AMD and myopic choroidal neovascularization are drusen and the type of atrophy. We're going to go over, you guys have seen a lot of geographic atrophy, I know, at the VA, but we'll also go over what atrophy looks like in myopic degeneration. There's specific subtypes, diffuse patchy or macular atrophy, and they can look different from geographic atrophy. And the other good thing that distinguishes myopic CNVM from AMD is that myopic CNVM often responds to a few injections. So unlike AMD, where I start people on a treat and extend, in myopic CNVM, I usually give them 2 injections and then just do PRN treatment after that. So here's an example of another myopic choroidal neovascular membrane. Here's the color picture with the Fuchs spot again, and you can see that shows up pretty early at 0 seconds. I don't know about that. And then leaks later. And you can see this is like fairly characteristic. There's subretinal hyperreflective material, but there's no fluid. So this is why it's really important in these patients to compare the old OCT to the new, so that you would detect any new subretinal hyperreflective material. So this patient, he received intravitreal Avastin twice, and then we observed him every 3 months. He didn't have any recurrences for a year. His symptoms completely resolved, and his visual acuity was 20/30. So after you get a choroidal neovascular membrane, a Fuchs spot develops. It's hyperpigmentation is kind of a reaction to that. And then later, you can also develop an atrophic spot. This is in different patients. So this patient, she's a 34-year-old female contact lens wearer. She says, I need a new contacts prescription. She also says that she's never been able to see 20/20 and that her mom had a retinal detachment. What do you think her glasses prescription is?
-12
Rachel?
or -30.
Yeah, I don't know. That's pretty, it looks like pretty stretched on her retina. -15, I don't know.
Okay, all right. Straub, we're playing a guessing game. Can you hear us?
Yeah, I can. Sorry, I'm just finishing up with the patient. I'm
That's
gonna write a
okay.
note.
Yeah, we're just guessing what this person's glasses prescription is. Teresa said -12. Rachel said -15.
Oh. Can I just be weird and say -2?
Yeah, I think that's a very good guessing strategy.
Can't go over.
Okay, so Rachel wins. She's about -17, -18. So what are the fundus features that tell you she's a high myope here?
So there's peripapillary atrophy.
Yes, that's very characteristic.
And then
Be on the 6th.
Sorry. Someone else.
Sorry, I'm just gonna pause for a bit. I have to go talk to someone.
Okay, bye. What else?
then
There's like chorioretinal atrophy.
Yep.
And tilted disc as well.
Yes, very good. The other thing I notice here is that she has a very blonde fundus. So you can, by blonde fundus, I mean you can see those choroidal vessels really well. So speaking of blonde fundus, I did my medical school ophthalmology rotation in Camden, New Jersey. And when I came to Utah and started my internship, I saw someone who looked like this. And I asked Trent Richards, like, what are all these things that I'm seeing, these red squiggly lines? Like, what is wrong with this person? And it took him a while, and he's like, oh, this is because you haven't seen the retinas of blonde, blue-eyed people before. So yeah, definitely the pigmentation of the RPE, affects how well you can see the choroid. And in myopes, because everything's so much thinner, like the RPE is thinner too, their fundus is much more blonde. And that's another feature that can tell us either that someone's blonde or that they're, a high myope.
I have a question too. So a few days in the OR ago, Dr. Hartnett referred to our patients who were doing an exam under anesthesia fundus as tessellated. Yeah. And it was a term that I hadn't heard. So is that a tessellated fundus? I didn't quite understand what it meant.
Yeah, so we're going to cover tessellation, but basically it means that the choroid is more visible in part of the fundus, and it's usually the posterior pole compared to the rest. And it can be pretty subtle, but that's what that is. Although I thought that patient you could see the choroid pretty well everywhere, not just the posterior poles. Yeah. And there may be a difference in how people use terms. So we talked about the tilted nerve and the peripapillary atrophy. So sometimes that atrophic zone is actually so atrophic that there's no choroid there. Normally with peripapillary atrophy, there might be not much RPE over it, but then it's called a scleral crescent. There also may be a macrodisc, so a really large optic nerve head, and it's thought that that arises from irregular stretching as the globe elongates. And people also think that the stretching and thinning of the optic nerve may also explain the risk of normal tension glaucoma that's a lot higher in high myopes. So here, we're gonna cover Teresa's question. So a tessellated fundus. So that the definition of a tessellated fundus is visible, well-defined choroidal vessels around the fovea and the arcades. So you can see that in this particular patient, it's a lot more visible here than elsewhere. And so this is the mildest category or the lowest category of myopic maculopathy. And myopic maculopathy is a term that refers to these series of findings that result from thinning of the RPE and choroid. So category 2 is diffuse chorioretinal atrophy. So that's when it gets to a higher level than just, oh, I can see the choroidal vessels a little better. It's a yellowish white appearance of the posterior pole. And here's an OCT where you can see that the choroid is basically, barely existing here, and you're just directly seeing the sclera beneath. And that corresponds also to this area. And the RPE is not looking so hot in that same area either. So category 3 of myopic maculopathy is patchy chorioretinal atrophy. It's when it progresses to the point of like really having these well-defined areas, and they can be grayish, white, or yellowish, as in this case. And on this OCT, you can see that even Brooks membrane is ending right here, and the RPE is ending here as well. So as that everything's getting thinner, defects start appearing. Category 4 of myopic maculopathy is macular atrophy, and it's a well-defined chorioretinal atrophic lesion in the fovea. Usually that results in really poor vision. And there, you can see on this OCT that there's really thin retina, no RPE, basement membrane, it's Brooks membrane or choroid in this region. So we talked about myopic maculopathy as being those atrophic findings, but there's a whole bunch of other definitions that are thrown out there and are kind of confusing. There's pathologic myopia, myopic retinopathy, myopic degeneration, progressive degenerative high myopia, which is the favorite ICD-10 code that comes up when you do this in EPIC, and high myopia. So what is pathologic myopia? So that means that you have high myopia, and one definition is that your refractive area is more than 6 diopters of myopia, and some characteristic retina problems. So just being really nearsighted is not enough to call it pathologic. There's some pseudo synonyms for pathologic myopia that people have used kind of in like varying ways: myopic degeneration, myopic retinopathy, and progressive degenerative high myopia. The things that aren't pathologic myopia are a tessellated fundus. Even though that's a characteristic, retina problem, they're not calling it bad enough to be pathologic myopia, because these patients are really unlikely to have any problems over the next 10 years. So what are those characteristic retina problems? I guess I should be asking you guys that define pathologic myopia.
Risk of retinal detachment, like we talked about.
Yeah, I don't think, even though that's like a myopic retina problem, since emmetropes are, get retinal detachments at a fairly high rate, they don't consider that to be pathologic myopia.
What about chorioretinal atrophy?
Yep, exactly. And what's that term for the chorioretinal atrophy?
Retinal degeneration?
Myopic maculopathy.
Myopic maculopathy.
It's okay. There's a lot of terms around here. And then, yeah, so let's go to the next slide. So here are the things that would characterize pathologic myopia. We talked about myopic maculopathy, choroidal neovascularization, Fuchs spot, which is a sign of choroidal neovascularization, lacquer cracks, staphylomas, and myopic traction maculopathy. We also talked about that there are retinal problems that emmetropes get, but in myopia, it can be more frequent and harder to fix. And these are macular holes, retinal detachments, retinal tears, retinal holes, and lattice. So, we talked about the myopic maculopathy or chorioretinal atrophy. We talked about choroidal neovascularization. So next we'll talk about lacquer crack staphylomas and myopic traction maculopathy. What do you guys think this looks like?
Let's see, there's a tilted nerve with peripapillary atrophy and kind of that scleral crescent.
Well, I don't think this looks like bare sclera because it's not that white.
Oh, I see.
This one peripapillary.
But the angle between the vessels is really narrowed.
Yep.
And does this patient have a history of prematurity?
I don't know.
And then there's some pigmentary changes in the macula.
Yeah. What diagnosis do you think of for this?
Maybe AMD. Or myopic CNV.
Okay, good. What else? Rachel?
Is that a lacquer crack?
Yeah, this is a lacquer crack. Very good. So it's the fact that they're kind of linear like this really indicates that this linear area of choroidal atrophy is a lacquer crack. And lacquer cracks anatomically are thought to be disruptions of Bruch's membrane, probably due to the choroid also being stretched in that area. As you can see in this, they have the chick model of myopia where they put a goggle on the chick. And this is a cool picture of the choroid from one of those chicks, probably in the region of a lacquer crack. Lacquer cracks can bleed. Sometimes the bleeding can be from choroidal neovascularization, or other times that can be just from the crack formation. However, the way to distinguish these two things is by FA, where there will be leakage if there's a choroidal neovascularization, and therefore the person would need treatment. Early cracks can be really difficult to perceive, but they can become more obvious over time. This is that same patient, I think. Is it the same patient? I don't think it is, but it's just the lacquer cracks are more evident in this photo from a couple of years after the first. Okay, what do you think this diagnosis is that I'm trying to show you?
Staphyloma.
Yes, very good. So you can see that this part of the photo is in focus, but this part of the photo is actually not in focus because it's so much closer to the camera than the rest of the retina. And this part is just really pooched out. So the definition of staphyloma is a localized outpouching of the sclera. We think that they form slowly over time, and the choroid is really thin at the edge of the staphyloma. A staphyloma can be many different shapes. And these can create traction on the retina because the vitreous and the inner limiting membrane and the blood vessels are not as flexible and not as able to protrude outward as the sclera. So another problem that occurs because of that outward movement of the sclera is myopic traction maculopathy. What do you see going on in this macula here?
If I looked at it and didn't know anything, I would say it looks okay.
Okay, yeah. Yeah, so what I would say is myopic traction maculopathy was very hard to appreciate. We kind of didn't know it existed before spectral domain OCT came around. But when you look at this person's OCT, you can see, wow, that retina is really not normal. There's all this fluid in the outer retina. So this is a picture of myopic foveoschisis. This schisis tends to start in the inner retina and then move outward over time. This patient that I just showed you was amazingly 20/40 and asymptomatic. And the decision was made to observe them. Over 3 years, things didn't change for most patients with myopic traction maculopathy. 4% of them had spontaneous regression, and 12% of them did have progression and worsening. So in patients that have this myopic foveoschisis, there can be a couple different ways in which it progresses. So if they have more axial traction, it's thought that they can get a macular hole. And it's thought that if they have more tangential traction, that's when it leads to a macular detachment or subretinal fluid in the macula. And some unlucky people can get both of these at the same time. So here are some pictures of how that patient progressed. So like I said, the fluid moved outward. So it was in this outer nuclear layer, and then it moved to subretinal. And then this is what we'd call a retinal detachment or foveal detachment due to myopic traction maculopathy. It's different from a rhegmatogenous retinal detachment. And you can see that, however, even though they developed this macular detachment, they were still 20/40. So we kept observing them. And then actually the fluid decided to go back into the outer retina, still 20/40. But then for whatever reason, things progressed and they developed a little, I think they have a little macular hole here. I can't really tell based on this image. And they were 2200. So at that point, the surgeon decided to operate and peel the inner limiting membrane, because if you'll remember, that inner limiting membrane is what's causing part of this traction because it's not as flexible and able to move outward. And their vision did improve to 20/80, but not to what it was before, not that much beyond, you know, what they were before surgery, 2200. So that's why I feel that we shouldn't really jump into these types of surgeries unless the vision is really seriously affected. So here's another case, a 50-year-old female. She had noticed 2 days of decreased vision in the left eye, and she was 20/60. And what do you guys see on this image?
It looks like she has the schisis that's in the outer nuclear layer, and then she also has a full thickness macular hole.
Yeah, so she has a macular hole and that schisis there, so myopic foveoschisis. So, which is a type of myopic traction maculopathy. So we saw her and things were pretty busy, so we scheduled her for a vitrectomy 4 weeks later. And she called 1 week later saying that the spot is bigger. We can see that this subretinal fluid is a little larger, but she was reassured, you know, you're gonna have your surgery scheduled. We, you know, don't have any time to do it sooner. It'll be okay. But then 3 weeks later, she called and she said, I really can't see anything out of my left eye. And she became count fingers at 1 foot. And what do you see here?
It's attached.
Yeah, so now she has a macular detachment as well as a macular hole from the myopic traction maculopathy. And you can see the subretinal fluid area here. You can see where it's more transparent right in the middle from the hole.
Did she not have a little bit of a foveal detachment beforehand as well?
She did have a little bit. Yeah, definitely. So she had vitrectomy, inner limiting membrane peel and gas, and she did well. She was 20/40, so we were pretty happy with that. She was really happy. Although it was kind of scary to us. You know, normally we think of, oh, okay, macular hole, like you could wait to get it fixed, but in her case, things really progressed significantly. Myopic macular holes can occur with or without the other signs of myopic traction maculopathy, like the foveoschisis. They're much more difficult to close because of that greater degree of axial and tangential traction. It can be really hard to see the hole. Like I can't tell that this patient has a hole. So a standard treatment, I'd say probably is vitrectomy, inner limiting membrane peel with a flap to help with hole closure, and gas. I think this is a picture, this is a video of doing a ILM flap. It can be challenging to raise an intact flap. I just thought it's a nice fact to point out that the ILM is 2.5 microns thick, and that's what we're trying to peel off here. And so I think I'm doing like the technique that George Williams told me about, where you kind of raise it up like a door. And then when you aspirate the subretinal fluid, as I'm showing you here, that flap kind of rolls over the hole again, but the hole in the flap never lines up with the hole in the retina because that ILM shrinks a bit compared to the area where you peeled it off. Oh, so here's a OCT of that same patient where it was really hard to see the hole.
You don't take the ILM completely off. You like peel it back and then you just let it.
Yeah, you like leave a hinge like where it's attached in like one quadrant.
What is the benefit of that?
It's just really hard. Like if you completely peel it off, it's just really hard to get that thing over the hole again to stay over the hole. So it's easier if it's
like fluid from getting underneath.
It's not like flying free. Because if you try to do the free ones, I've definitely accidentally sucked it up into the soft tip before while doing the air fluid exchange, and then you're like, oh well, there you go. So next we'll talk about myopic retina problems that emmetropes get, but that myopes get more often and are harder to fix. So there are macular holes we just talked about, retinal breaks. We'll talk about acute symptomatic and asymptomatic horseshoe tears, lattice degeneration with atrophic holes, and retinal detachments, both acute and symptomatic and chronic and asymptomatic. This might be overly detailed. Let's see. So this is a 64-year-old female veteran. She had a history of high myopia, status post LASIK, and cataract surgery. She was picking up something from the garage floor. Her and her husband like to work on old cars together. And she saw a sudden cloud of vision over her left eye. She was 20/60. She had some mild vitreous hemorrhage and some lattice. I think she was seen by the resident at the VA. They decided to follow her closely because they were highly suspicious she had a tear, but they didn't see one. 2 weeks later, they still didn't see a tear, but the resident had ordered a fluorescein to rule out vascular disease as a cause of her vitreous hemorrhage. And the photographer pages me while I'm operating to ask if I want to look at the photos. I was like, that's weird. That's never happened before, but I didn't make the connection that she didn't want to, I don't know. She didn't want to like make a diagnosis and like overstep her role. So anyway, I looked at the photos later that evening, and this is what I saw. So it might be kind of hard to tell, but can you guys see anything here in this area?
Like pigmentary changes and maybe some heme. And
So
it looks like
pigmentary changes. I'll just kind of circle this area here.
well, there's a hole.
So in optos, yeah, actually the retinal tears can show up often on optos that we don't appreciate in person. So it can be, but basically you can see the edge. Oh, that was very bad drawing. Yep. You can see the edge of where the retina ends there. And I think this is the flap, or maybe this is the flap. And you can just see the choroid better here because that retina is gone off of the RPE. So I'll show you, let's see. Do we need to get out of annotation mode? Okay, so there's an acute symptomatic horseshoe tear. I guess I've blown it up here where you can really see that torn edge of the retina. And this is her other eye. Rachel, what do you see here?
So she has what looks like she probably had an old tear temporally, where it looks like it's kind of scarred down with all the pigment around it.
Are you talking about this area or this area?
Below it.
This area?
Then, yes. But then above it, I don't know, there might be like a little bit of a tear, a little bit of horseshoe tear right above it, right there.
Yeah, I don't think that this lower area looks like I don't see a tear. I just see chorioretinal atrophy. But up here, what I see blown up here is a tear. Let me get my annotation. Oh gosh. Let me get my annotation abilities back. Yeah, so here you can see the edge of the tear. That's like the contracted flap. And then here, and then in here, it's like bare RPE because there's no retina over it.
Are there pigmentary changes over that one?
Not really. I mean, I guess these are some, oh, sorry.
Like there's some right next to it, but really not like, that's not like a chronic,
I'm not sure if that's
tear.
related to the tear or not, just based on, you know, the weird fact that it's like this and the tear is like this. So. So the next day, I call the patient into clinic, and I'm not the one in clinic. The senior fellow is the one in clinic, and they examine the patient's left eye and say, there are no tears. So a few days later, I insist on showing the senior fellow the photos, and well, he was all like, you know, my indirect exam is much better than any Optos photo, but anyway, he calls the patient in and does see those tears, lasers them in both eyes, and finds a number of tears, more tears that were not picked up in the initial photos. So I think the moral of this story really is that Optos can see photos that retina specialists, even very good ones, don't see, but and also that a retina specialist or a person doing indirect ophthalmoscopy with scleral depression can see tears that the Optos can't see. So yeah, it's definitely something to think about. This lady's retina stayed attached and she continues to work on cars with her husband. So acute symptomatic horseshoe tears, this is stuff you guys know. A third to a half will lead to retinal detachment if untreated. We usually treat within 24 hours, but you know, the laser scar takes about 4 days to work. So, you know, when you're trying to help a patient understand, like, do you need your tear lasered at 11 p.m. by the retina fellow, or could the retina fellow laser them at 10 a.m., you know, I think over the scale of how quickly these progress and how quickly the treatment works, it's very reasonable to have them do it the next day. Although my retina fellows, when I was a resident, were very, very kind. Came in at night. So, you know, the treatment isn't perfect, but it does reduce the retinal detachment risk to less than 5%. I think it's really important after you laser someone's tear to have them do daily monocular vision checks. I think that can be really helpful for detecting an early retinal detachment. So I train everyone on that after I've lasered them. So in contrast, you know, chronic asymptomatic horseshoe tears, so how do you tell that they're chronic? The pigmentation can tell you, the flap contraction can tell you. Maybe I'll try to illustrate the flap contraction thing. So what I mean by contracted flap is, I should turn on my video so I can see if I'm showing you guys correctly, is that, you know, usually when a tear is fresh, like this, like the flap exactly matches the hole. But if it's been there for a while, the flap starts to shrink up, and it looks like it's not going to go over and cover the hole anymore. And that is an indication of chronicity. Chronic asymptomatic horseshoe tears are unlikely to cause retinal detachment. Why are they? Like, what's different about them? I'm going to pull this back to the previous slide so I can ask you guys.
I don't know. I actually don't, I didn't see your slide, but I don't know. I mean, I guess that like at some point, like they would get contracted and maybe there's like a fibrosis and scarring down. So then you can't get fluid underneath the retina and then it doesn't detach, but I don't know other than that guess.
Yeah, that is good to like think about. Is there something different about a tear once it's chronic? That means it's less likely to detach from there. Unfortunately, the pigmentation that forms in the area of a chronic tear doesn't have any retinopexy effect, so it doesn't protect from retinal detachment from an old tear. Any thoughts, Rachel?
If it is kind of asymptomatic, then it's probably been there for a while anyway, and either that means like it's been there for years and I haven't noticed it and you're just seeing it, and so it's probably not going to keep going and having issues. Or maybe that if it was because of a vitreous attachment back then, like now the vitreous is fully detached and so there's not really much traction left on the tear.
Yeah, so I think it's more, or in general, people think it's more like that sort of story where there's not any sort of healing or adhesion to the retina that improves with the chronic tears. It's just that those tears didn't cause a detachment, when they happened, and therefore they're probably not going to cause a detachment in the future. Whereas if it just happened, you don't know if it's going to be one of those that causes the detachment or not. So for example, like if you're seeing the patient on, February 2020 for their yearly eye exam, who knows like when that tear happened? Yeah, it could have happened like a month ago, but it also could have happened like, 8 months ago, and hasn't done anything in those last 8 months. So here's another diagnosis. This patient has had lattice for years. He sees floaters for years and gets regular eye exams. What do you guys see on this optos photo in the periphery?
Yes, lattice and atrophic spots, supratemporally and inferior-temporally.
Yeah. Yep, here's some lattice, and these are atrophic holes. I really like how the Optos highlights them here. And this looks similar in the other eye. This patient was observed over 7 years and remained totally stable in terms of no, detachment from these lesions. So what is lattice degeneration? There's this characteristic appearance. How would you guys describe the appearance?
The appearance itself?
Yeah, what does lattice look like?
It kind of looks like this windy, linear, usually hyperpigmented stuff in the periphery that can have these little, sometimes like these whitish lines that crisscross over it.
Yeah, definitely those whitish lines that are crisscrossing. They're actually oftentimes on sclerotic blood vessels. And you mentioned the pigmentation. Lattice can be hyperpigmented, or it can just be those white lines. In those areas, the retina is thinner and the vitreous is really firmly adhered, and yet it's also liquefied. So this is like an amazing picture of kind of how there's some holes in the vitreous right over the area of lattice. Lattice is in 77% of the population, but retinal detachment, fortunately, is fairly rare, only 7% risk in someone with lattice. You can observe them. You definitely monocular vision checks I'm a big fan of. And you could laser lattice. You wouldn't be faulted. All these things are done by by retina specialists, observation and treatment. However, sometimes those atrophic holes in the lattice can cause retinal detachment. So it's not like they never do. So here's another story. This is a 60-year-old male. This is from Wisconsin. He was a high myope until he had cataract surgery a year ago. He got a bunch of floaters 2 weeks ago while he was up north hunting. But of course, he couldn't cut his hunting trip short. So he had to come into the eye doctor only once he got back. But while he was up there, he realized he couldn't see his lower right vision in the left eye. And of course, what do you think is his diagnosis?
RD,
Yep. Yeah, so this is a retinal detachment, and he's got a retinal tear over here. So in an emmetrope, the lifetime risk of retinal detachment is about 0.4%. In a high myope, it's 9%. In a high myope with lattice, it's 35%. At that point, I'm really crossing my fingers. No, I don't think I have any lattice. At least the residents tell me I don't. Okay, so but why are myopes more likely to get retinal detachments? They have early vitreous liquefaction, early posterior vitreous detachment, and lattice degeneration. These are all risk factors. Here's another case. She's a 20-year-old female college student. She's a -4. On her yearly eye exam, they noticed a confrontation field defect that was confirmed on a 30-2, and they referred her to neuro-ophthalmology. What do you guys think is the diagnosis?
Retinal detachment.
Yeah. So yeah, so you can see kind of an edge here where in this area, like it's pretty subtle. It's not like one of those like major bullous ones, you know, like our previous guy where it's like, okay, a pre-intern, you know, could see this retinal detachment. But this, it can be a lot more subtle. And a lot of times on exam, like all you're picking up is that I can't see the choroid as well here as I can here. One thing that is really helpful on indirect exam is using that red-free light, and it oftentimes will highlight like how well you can see that red, you know, choroid in different areas and show you exactly how far that detachment extends. Because sometimes you'll see someone like this and like you see fluid going up to here, but they're like count fingers. But then if you turn on the red free, you might see that actually there is shallow fluid up here in the macula. But this patient didn't involve her fovea, and she has a chronic asymptomatic retinal detachment. So in this case, you know, we felt like this thing had been there probably a really long time, so we weren't in any rush, and she wanted to wait till winter break. I think it was like, you know, maybe the fall when we saw her, and she had a scleral buckle without drainage, and she was attached the very next day. So here's another case. This guy's a 61-year-old male. He had a retinal detachment fixed in the left eye 20 years ago, and this is what it looks like. And his right eye is 20/25, the left eye is 2/200. He hasn't been to the eye doctor in a long time. What do you guys see here?
So he's got an inferior detachment, and it maybe looks like dialysis a little bit.
Yeah, you can see this tear over here.
Oh, that's the tear.
Oh no, I think it could be a dialysis. I can't tell because it's like at the limit of the Optos photo. It's not, I'm not sure whether it's at the aura or it's a tear.
But then there's this like all this pigmentation along the like a demarcation line.
Yeah, this is a demarcation line. So once that retinal detachment has been pretty chronic, then you start seeing RPE changes under there. So what do you guys think we should do here?
Watch him.
Okay. Yeah, he's a monocular patient. Like he feels like his vision's fine. He's probably gonna be fine.
Well, I guess, I mean, the tear is chronic, right? It's got pigment in there. It's been there for a while.
But it's not just a chronic tear.
It's not a detachment, sorry. But it's, I mean, oh wait, is he phakic or pseudophakic?
He is phakic.
So, I mean, if you do a surgery, then he's going to need cataract surgery. How much NS, nuclear sclerosis, does he have?
Not that much, but it was, yeah, enough to make it hard to see this.
I mean, would you just do vitrectomy and retinotomy and or retinectomy, sorry, and like PPV, laser it down, even though it's been chronic? But like, what are the chances if this is chronic that you could just watch it?
I think very high. I mean, obviously this thing is chronic, so it's probably not moving fast. But on the other hand, like, do you want to let this 20/20 guy potentially get a MAC off situation? What are there other options for what we could do?
Buckle.
Yeah, a buckle. A lot of times, like with the inferior detachment, that's a great option. What else could we do?
You could complete the laser.
Yeah. What do you mean by complete?
Well, like he does have some pigment there, but you could kind of demarcate the R&D.
Yeah, exactly. So we talked about how like these pigmentary changes don't mean that the retina is actually stuck to the RPE like it would be in a laser retinopexy. But I think that's what we elected. Let's see. Yeah, so my attending really, he mulled over this for quite a bit because like you don't want this guy to get a MAC off RD, right? It's this 20/20 better seeing eye, but you don't want to go in and do surgery when he feels like he's fine. Like what if he has a complication? He's monocular.
Right.
And then also he thought about laser barricade, but then, I haven't done laser retinopexy through the macula before. I mean, I have once in my life on this guy. So yeah, because you generally don't want to like take away someone's macula, but anyway, we figured that was like the best of all the options, was like doing something to try to like hold things steady and prevent his macula from coming off, but also not going so far as an invasive surgery, which could have significant complications. He didn't notice that his superior vision was gone, and he didn't notice any additional superior vision loss after the laser, thankfully. I think I did make it kind of skinny in this area. Rarely, retinal detachments can resolve spontaneously. This guy was like a 16-year-old male. Oh, let's see. And he actually came in for a retinal detachment in the other eye, and we noticed this like weird pigmentary area. And he also did have some holes up here where you can't see on the optos with fluid. So, but basically, it seems like he had a larger area of retinal detachment. In that area, the RPE started changing what it looked like, and then it kind of regressed on its own. So it's thought that, in a retinal detachment, you've got a hole or a tear, right? And so you've got fluid flowing into the hole and under the retina, but you also have the body's ability to pump out subretinal fluid. Like that RPE pump is really pretty strong. So it's a matter of like how the balance between those things. And somehow this guy's balance must have shifted from increasing subretinal fluid to decreasing, and his retinal detachment got better. So signs of chronicity: pigment, thin retina, being asymptomatic, and obviously signs of proliferative vitreoretinopathy. The likelihood of progressing for chronic asymptomatic RD is only 1/3, but only 5% of them progress to a clinical retinal detachment. So all the options of treating them we talked about are valid depending on the patient's situation. So we're getting to the end here. I'm just going to talk briefly about types of myopia because I felt like this wasn't talked about much in my residency either. So there's juvenile onset myopia or youth onset myopia. School age myopia usually occurs after age 7. It's multifactorial. Definitely family history plays a role, and probably genetics, but we haven't found the genes yet. Near work is a major risk factor. So definitely, being on your phone and et cetera. Once juvenile myopia appears, it almost always increases. And on average, it increases 1/3 to 1/2 diopter per year, but progression usually slows or stops in the mid-teens. In contrast, early onset high myopia is when people are more nearsighted than 6 diopters before school age. Oftentimes, these patients have ocular abnormalities like coloboma or retinal dystrophies or fever. And they can also frequently have other systemic abnormalities. For example, Down syndrome kids are a lot more likely. And some other things to think about are Stickler syndrome, Marfan syndrome, Ehlers-Danlos, and prematurity. And sometimes eye findings can be the first sign of a systemic problem. So it's probably worth it to do some sort of workup. One could consider doing an ERG. You could consider, a physical exam for looking for signs of Stickler or Marfan. So here's a table just showing that of the people who had early onset high myopia, 54 of them didn't have anything else going on, but a substantial number of them had other issues going on: amblyopia, retinal dystrophy, and some other rare things. In this other study, they found of 112 patients, there were some developmental eye abnormalities, for example, anterior segment dysgenesis, and a fair number of retinal dystrophies, developmental delays, and syndromic conditions. So how about this patient? He's a 9-year-old. He says he has difficulty seeing in the dark, and his visual acuity is only 20/70 OU best corrected, and he's about a -10. What do you guys see here? Is anyone
The
there?
OCT, yeah, the OCT of his macula looks normal.
Yeah.
And then like he just has a shiny ILM. Macula looks okay.
Eyes normal.
Yeah, it looks very normal.
Yeah. How about this? This is a full field ERG, and dark adapted means that it's a scotopic. So it's more testing his
Rods.
rods.
Yeah.
And then 10 is just signifier for the intensity of the bright flash.
I think it's abnormal, right? It's like negative.
Yeah, so this is
is this the one that has the differential that I'm supposed to remember for OCAFs?
Yes. Can you think of anything?
Rachel Patel knows.
Congenital stationary night blindness.
Yeah. Yeah, that's definitely what I will let you guys review the differential diagnosis of electronegative ERG, because I'll probably miss a few things on there on your own. But this is CSNB, and specifically, I can't remember the mutation, but maybe but certain mutation in CSNB can be associated with high myopia. So these are just, pictures of Stickler syndrome and Marfan syndrome. It's interesting, when you see a kid, and they look like, it's obvious to you, but they've never been diagnosed before. So in summary, pathologic myopia means high myopia plus myopia-specific retina problems. Some problems, unfortunately, there's no treatment for: myopic maculopathy, which is the chorioretinal atrophy; staphylomas, lacquer cracks without choroidal neovascularization. Some problems may need treatment: choroidal neovascularization or myopic traction maculopathy or foviostesis. And there are retina problems that affect emmetropes, but affect myopes more, that may need treatment, that we talked about some of the our understanding of why chronic things can be more likely to be observed. And we also talked about the types of myopia and how congenital high myopia really needs a workup for other problems. That's all I have. Thank you guys so much, for your enthusiasm for learning and your spending your time doing this. I know I have a lot more fun things that you would like to do.
This is good.